Can you all hear me? Thumbs up. Yeah, okay. And everybody can see the lecture on the screen? Okay, perfect. Well, I'm Katie Keck. I'm one of the pediatric ophthalmologists here at Prisma. And today we're just going to go over some basic ophthalmology principles for the pediatrician. And please feel free, if you have a question, to chime in. I'm happy to answer them as we go along, or you can ask at the end. Either way is fine with me. So today we're going to just cover some general ophthalmic principles. We're going to talk a little bit about pediatric eye screening or vision screening in the pediatrician's office, and then also touch on amblyopia. So first of all, some common myths that may come up in talking to parents that you can kind of provide some reassurance about. So the first one, reading in the dark will permanently affect your vision. So that is not true. It doesn't affect your vision. It can cause some eye strain or headaches, but won't cause your vision to be affected permanently. Another big one nowadays is a lot of parents ask about prolonged screen time and the impact that has on kids' eyes. Honestly, we really don't know long-term what effect that has, but in the short term, again, it doesn't permanently affect the vision. It can lead to some eye strain, but otherwise doesn't cause any changes. And I know blue light glasses are a big thing for kids in schools nowadays. Really, there's no evidence out there to support their use at this time. They definitely won't hurt the eyes, but again, probably not much benefit to them either. Another myth, sitting close to the TV will permanently affect your vision. And actually, kids are really good at focusing up close, much better than adults are. So often they just kind of develop a habit of sitting close to the TV, and that's not going to hurt their eyes either. And often it's not necessarily because they can't see, it's just because they can see up close, and so they like to be close to things. The third one, eating carrots will help your vision. So carrots have vitamin A, which is necessary for good vision. Vitamin A is used by the retina for some of the reactions that take place to help you see. But vitamin A is present in lots of foods, and the more vitamin A you get is not going to further improve your vision. And then the last one, wearing glasses will make your eyes dependent on wearing them all the time. That's not true either. As you get older, your eyes grow, and that's what causes your prescription to change. And, you know, when you first go into glasses, all of a sudden you can see clearly now. So when you take them off, the blurriness that you noticed was probably always there. You just didn't notice it until you saw a clear image through the glasses. Okay, so next, visual acuity. So how do we measure visual acuity and how do we document that? So it's written as 20 over another number, and we consider 20/20 normal. So that means that when you're looking at the eye chart from 20 feet away, you can clearly read that line on the screen. And it's important in kids to test each eye individually, because we can miss an issue with one eye if we don't. It's also important to test them with correction that they may already have. They may already be in glasses or contacts, and it's important to know that. So when we talk about the 20/20 acuity, if you think about somebody that can only read the 20/100 line, so basically what that means is that somebody who has 20/20 vision would be able to read the 20/100 line at 20 feet, and the person with 20/100 vision has to go back to 100, or sorry, I said that wrong. So the person with 2100 vision, what they can see from 20 feet, the person with 20/20 vision could see from 100 feet away. And typically we want the eye chart to be about 20 feet from the patient to get an accurate assessment of their vision. All right, so there are different eye charts that can be used for testing kids' vision. On the left here, you see the Snellen chart, which is what we consider the gold standard for vision testing. And typically we use this once kids are school age or once they're able to recognize all of their letters. If they're younger than that or don't know their letters yet, then typically the chart that we like to use is on the right here. This is called the Allen chart. So it has some different pictures. And this works well, again, for kids. They learn to kind of recognize the pictures and we can get an assessment of their vision that way. Under about age 2, it's often hard to get them to recognize the pictures even. And so then we're really relying on more qualitative measures to assess their vision. All right, so refractive error. So refractive error is referring to the need for glasses to give somebody their best vision. And it has to do with how light is bent through the front part of the eye to focus an image clearly on the retina. There are 3 different types of refractive error: myopia or nearsightedness. So that means that you have clear vision up close, but your distance vision is blurry. Hyperopia or farsightedness is the opposite. So you see well in the distance, but things up close are blurry. And then astigmatism refers to an abnormal shape of the cornea, causing light to be focused unevenly on the retina. Astigmatism can be present with either myopia or hyperopia. And there are several corrective options for refractive error, most commonly glasses. As you get older, contact lenses, and then as an adult, refractive surgery may become an option. But typically that's not an option until you're an adult, because we want the eye to be fully grown and for the prescription to be stable before we consider that. So here's just a little illustration of how kind of refraction works. So light hits kind of the front surface of the eye, it goes through the cornea and through the lens. Both of those bend the light to focus it onto the retina at the back of the eye. So with myopia or nearsightedness, again, vision is clear up close, distance vision is blurry. This is the most common refractive error in the general population. The eye is actually longer, and so the light is focused in front of the retina, and that's what causes your distance vision to be blurry. So typically for kids, they'll complain of not being able to see the whiteboard at school, and oftentimes it starts in kind of school age. That's when we start to see myopia in kids. Earlier than that, it's much less common in younger kids, but definitely kids that are born premature are at higher risk for becoming myopic or nearsighted earlier in life. And on a glasses prescription, a minus sign in front of the numbers indicates myopia. So here you can see the light hits the surface of the eye and is bent, but it stops before it gets to the retina because the eye is longer, which would be nearsightedness. All right, hyperopia or farsightedness. So most children are farsighted early in life, and this is very normal. And that's because their eyes are small and they need to grow. So in this situation, light is focused behind the retina. And so that causes images to be blurred up close more than in the distance. But actually for kids, they're able to accommodate or focus really well So this being farsighted actually doesn't really cause them any problems, okay? They're able to see clearly in the distance, and then they can make that focusing effort to see well up close too. So typically, or oftentimes, we don't prescribe glasses for farsightedness unless it's fairly significant. So on average, young children are about 3 diopters or have about 3 diopters of hyperopia, and that's fairly normal. And again, we don't often give glasses for that. So on a glasses prescription, there will be a plus sign in front of the first number indicating that they're farsighted. And then astigmatism. So astigmatism is caused by a difference in the surface curvature of the eye. So instead of the cornea being shaped like a sphere, it's shaped with a greater curve in one axis, so more oval shaped. And so when light hits the surface and is bent to the back, all those light rays don't come to the same point on the retina. And so that can cause some blur or distortion. And so when we put astigmatism correction into glasses, the strength of the lenses is stronger in one axis of the lens compared to the opposite axis, okay? And again, you can be either nearsighted or farsighted and also have astigmatism. All right, and then this slide, it just kind of shows how glasses work. So at the top, this is a concave lens. This is the type of lens we would use for a farsighted or hyperopic eye. And so it bends light. So you'll see here, it causes the light to be bent more so that it moves forward to hit the retina. Whereas at the bottom, a convex lens, so this is what we would use in somebody who's nearsighted, it actually causes the light to be bent less so that it can reach back to the retina and give a clear image. And actually, you can tell if somebody is farsighted or nearsighted just by looking at their eyes through the glasses. So if their eyes look smaller in the glasses, they're nearsighted. If their eyes look bigger or more magnified, then they're farsighted or hyperopic. So that can be a clue if you don't know their prescription. So why is it important to perform ocular screening? Well, many eye problems are actually pretty common. And really the important thing is that the earlier we catch them, often the more effective our interventions will be, since the first few months to years of life are critical to ensure good vision development. And this slide just shows how common many of the eye problems we see are. So definitely strabismus and amblyopia are going to be the most common things we see. All right, so let's talk a little bit about the red reflex. So this is one of the most basic and earliest ocular screening tests to use. And ideally, when you're testing the red reflex, you want to be about a foot away from the child in a dimly lit room, and you're trying to light up both pupils at the same time with the direct ophthalmoscope. And you should get a red reflex, which is basically just the light reflected back from the retina. So it's important to kind of start this early in life. So right away at birth, and then at all subsequent well child visits. And we're going to talk a little bit more on the next slide about kind of what you're looking for in the red reflex. But anything that's abnormal really should be referred to us. And then if there's any family history of eye issues early on in childhood, those kids should be referred for screening as well. Now, leukocoria down here at the bottom of the slide. So that's when the pupil looks more white. And obviously that can be a very serious sign. We worry mostly about retinoblastoma when we see a white pupil, but it can be a sign of other ocular issues too, such as a cataract So it's important for us to see those kids right away. So this test that we're talking about, where you're standing about a foot away from the child and illuminating both pupils at the same time, is the Bruckner test. So you're looking not only to see if the red reflex is symmetric between the two eyes, but also is it symmetric within each pupil, okay? So asymmetric red reflexes can indicate lots of things. It may indicate refractive error or need for glasses. It can indicate strabismus or misalignment of the eyes, or it may indicate an opacity in the visual system, such as a cataract. So looking at the top picture here, you can see that the reflex is actually not symmetric within each pupil. So this represents a refractive error. So this child is farsighted or hyperopic. And you can tell this because there's that lighter crescent at the top of the pupil that indicates hyperopia. And the higher the refractive error, the dimmer your red reflex will be. In the bottom picture, comparing the two red reflexes, so it's brighter in the left eye compared to the right eye, because the left eye is actually turned in towards the nose. So with strabismus, the eye that's misaligned is actually going to give a brighter red reflex, okay? And actually in this picture at the bottom, there's also another clue that the left eye is turned in. If you look at the corneal light reflex in both eyes, on the left side, it's actually displaced out towards the pupil margin, which indicates that the eye is turning in. And really with the red reflex, the more you look at them and compare them, the better you'll get at performing this test and knowing what's abnormal. All right, so vision screening. So vision screening is really important to detect amblyopia, which is treatable, but becomes more difficult to treat as the child gets older. It's much harder to treat after about age 5. So that's really why we recommend checking kids' vision, you know, as soon as they're able to read a picture chart or a letter chart. Vision development ends somewhere between the ages of 8 and 10. So once we kind of get to that age, we may not be able to treat the amblyopia, and that can lead to permanent vision loss in patients. So oftentimes as a pediatrician, you're seeing these kids prior to school age and testing their vision in the clinic. And sometimes that's supplemented then once they reach school age and get vision screenings at school as well. So any failed vision screens then are referred to us for a more thorough evaluation. So vision screening guidelines based on age have been published by the American Academy of Pediatrics, as well as the American Academy of, or the Academy of Pediatric Ophthalmology. And these are really kind of the important components of vision screening prior to age 3, when kids may not be able to read the vision chart for you. So, you know, asking parents about any family history of eye problems early on in childhood or in childhood. Probably the biggest things are looking at the red reflex and also looking at the corneal light reflex. So both of those can give you a lot of information about anything abnormal that may be there. Now, photo screening is something newer that a lot of pediatrician offices are starting to use. And really the recommendation is to not start photo screening until about 1 year of age. Prior to that, it's really hard to get a good, accurate picture of kids' eyes. But basically, it's a camera that takes a picture of the child's eyes and it looks at the red reflex and can kind of estimate refractive error and potentially screen for a misalignment of the eyes. It does not test visual acuity. That you really have to do with an eye chart. But it is a good screening tool to hopefully help pick up kids that may need further examination. And this is just a picture of some of the vision screeners that are out there. As a pediatric ophthalmologist, I don't know that one is better than the other. They all act very similarly. I know some of the offices around here use the Go Check Kids, which is kind of an iPhone that takes a picture of the eyes. But again, it's kind of just whatever's available to you. They all work fairly well. As far as kids that are a little bit older, so age 3 and up, these are really kind of the guidelines for referral based on visual acuity. So kids in kind of the 3 to 4 age range should be able to identify most of the pictures on the 20/50 line, with each eye individually standing about 10 feet away from the chart. As they get a little bit older, they should be able to get down a little farther, so 20/40 with each eye individually. And then, 5 and above, they really should be able to get down at least to the 20/30 line, if not better. All right, so moving on to amblyopia. So what is amblyopia? So amblyopia is reduced vision in either one eye or both eyes that's not directly due to a structural abnormality of the eye itself. So it has to do with lack of connections being made between the eyes and the brain early on in life. And again, vision development ends somewhere between the ages of 8 and 10. So after this, amblyopia is much harder to treat. But the 3 causes of amblyopia that we're going to kind of touch on a little bit here are visual deprivation, refractive, and strabismus. But first, just to go a little bit more into amblyopia itself. So for multiple reasons, the image can be poorly focused on the retina, which leads to poor development of the connections between the eye and the occipital cortex in the brain. So normally visual information travels from the retina through the optic nerves, then some of the fibers from each eye decussate in the optic chiasm, and then they travel through the lateral geniculate body, through the optic tracts, and back to the occipital cortex, where the information from both eyes kind of commingles. So both sides of the occipital cortex get input from each eye. So in amblyopia, here's a picture kind of the occipital cortex, and you can kind of see there's these what are called ocular dominance columns. And on the left side here, normally the cortex is getting input from both eyes equally, and you have these nice thick columns. However, on the right, if one eye isn't getting a clear image for whatever reason, those columns just don't develop. And so you can see on the right there, the columns just appear underdeveloped. So really, I mean, amblyopia is damage to the brain itself. Luckily, if it's caught early, potentially it can be reversed. All right, so the different types of amblyopia. So visual deprivation amblyopia. So because the first few months of life are especially critical to vision development, deprivation of visual input during this time may lead to difficult to treat amblyopia and loss of the ability to use the eyes together for depth perception and that sort of thing. So visual deprivation really refers to anything that is blocking the visual axis. So if you've got significant ptosis of an eyelid that's down over the pupil, it can block light from getting into the eye and block vision from developing. If you've got a cataract in the eye, or potentially blood in the back of the eye, blocking things. And really, it's important to try to clear whatever's blocking the visual axis as soon as possible to allow for good vision development. So typically visual deprivation really causes the most severe amblyopia and is probably the hardest to treat. So for example, at the bottom here, it talks about congenital cataracts. So really we want to try to get those out of the eye as quickly as possible, usually by about 6 weeks of age. And here's just some pictures of examples of what could be potentially causing visual deprivation amblyopia. So on the left, you see ptosis of that right upper eyelid kind of coming down over the pupil. So kids that present with significant ptosis really should be referred to us right away so that we can treat that amblyopia. And then on the top right, this child has cataracts. Bottom right, there's a scar in the cornea kind of right across the pupil, which may be affecting vision. The second type of amblyopia that we're going to talk about is refractive amblyopia. So there are two types, anisometropic and ametropic. So anisometropia refers to the refractive error or the need for glasses being significantly different between the two eyes. So one eye has a much higher refractive error than the other, and so that eye is not getting a clear image, which can lead to amblyopia in that eye. Ametropic just means that both eyes have very high refractive errors, so both are at risk of developing amblyopia. So again, both anisometropia and ametropia can just cause there to be a blurred image on the retina. And so the visual information isn't sent to the back of the eye, leading to amblyopia. And typically we treat this with glasses first. And depending on how much vision improves in glasses, we may need to add amblyopia therapy as well. So of the refractive errors, myopia generally is much less likely to cause amblyopia than hyperopia. And that's because in kids, their world is very much up close. So kids that are myopic or nearsighted actually have good vision up close. It's their distance vision that's affected. So again, they're less likely to become amblyopic from myopia. And, you know, typically if kids have high refractive error in one eye, but not in the other, we still put them in glasses, even though they may not need them for one of their eyes. And often these kids still need amblyopia treatment with occlusion therapy, which we'll touch on here in a minute. So the third type of amblyopia is strabismic amblyopia. So in strabismic amblyopia, the eyes are misaligned either horizontally or vertically, but most commonly horizontally. And so the child may develop a preference for using one eye and letting the other eye be misaligned. Now, if you or I, as an adult, had a suddenly misaligned eye, we would see double, we would have double vision. But because children are still developing their visual systems, they can actually suppress or ignore the misaligned eye to avoid double vision. And this can lead to amblyopia. So in the pictures here on the left, this would be esotropia, meaning an eye is turning in towards the nose. And then in the picture on the right would be an example of exotropia, meaning an eye turning away from the nose, out away from the nose. And in the picture on the right, you can see the right eye, the corneal light reflex is centered, whereas in the left eye, the corneal light reflex is way out kind of on the edge of the colored part of the eye, indicating exotropia. So the Hirschberg test is the corneal light reflex test. So you're shining a muscle light at both eyes and looking at where that corneal light reflex sits in each eye and comparing the two. So at the top here, In eyes that are straight, the corneal light reflex should be lined up in the center of each pupil. In the second picture, you can see the light reflex in the left eye is kind of pushed out to the edge of the pupil, indicating that that eye is actually turning in. In the third picture down, you can see the light reflex on the right eye sits lower than on the left, down towards the pupil margin, which indicates that that right eye is sitting higher than the left eye. And then in the last picture, you'll notice you can see less white of the eyes on the inside. However, the light reflex is centered in the pupils. So this would be an example of pseudoesotropia. You know, the eyes give the appearance that they're turning in because of those kind of skin folds in the corners of the eyes, but yet when you look at the corneal light reflex, they're nice and centered. And here's another picture of pseudoesotropia versus true esotropia. So on the left there, you can see she has kind of a wide nasal bridge and those folds of skin that kind of come down and cover the white on the inside of each eye. But if you look at the corneal light reflexes, they're nice and centered in each eye. Whereas on the left, this child also kind of has an appearance of pseudoesotropia with the white being covered in the cornea or being covered in the corners of the eye. But if you compare the corneal light reflex on the right to the left, on the left, it's kind of displaced out towards the pupil margin, which indicates that that eye truly is turning in towards the nose. And then just a few pearls for strabismus. So esotropia, or an eye turning in, is commonly associated with farsightedness or hyperopia because kids have to make that focusing effort to see things up close. And when they make that focusing effort, it can cause an eye to turn in. And so oftentimes then we put kids in glasses for that, and that helps keep their eyes straight. So in this situation, oftentimes the esotropia will be more noticeable when the child looks up close at things. Exotropia, or eyes turning out, is often intermittent and can first present when a child is tired or sick. That may be when parents first notice it. And then much less commonly, rarely, strabismus can be due to really bad things such as retinoblastoma, or things going on in the brain causing a cranial nerve palsy. But that's much, much less common than the above. So treatment for amblyopia. So really it's kind of treating the underlying problem first. So if there's a cataract blocking the visual axis, we take it out. If there's a need for glasses, we prescribe glasses and put them in the glasses to help. So that's kind of the first step. And then kind of whatever amblyopia is remaining after that, then we treat that by forcing use of the amblyopic eye by limiting use of the better eye. And we can do that in two ways. First of all, patching the good eye to force them to use the amblyopic eye, or penalizing the good eye with eye drops that dilate the pupil and blur the vision in the good eye. And both of these treatments have advantages and disadvantages. I've kind of listed some of those there on the slide. Really, both treatment options have been shown to be equally effective when they've been tested head to head. And so it's really oftentimes kind of up to parents in which option they think will work better for their child. I will say I often start with patching. And if that doesn't go very well, then we talk about switching to atropine. But again, really either option can be used. And I think actually that may be all I have for you today. Are there any questions I can answer or any thoughts?
Just a quick question. It seems like the light reflex would be asymmetric. Baby wasn't looking directly at you. Is there any way to be like 100% sure that the kid's looking at you?
So yeah, so I would say my best advice for that is you need to have something that's going to capture the child's attention. And actually, I'm in one of my exam rooms right now. One of the lights that we use that works really, really well. Let's see if I can kind of hold it up. We have this light that you turn it on and it's got these lights, and I just buy these on Amazon. But this is one of the best tools for checking kids' eyes because it just kind of captures their attention, mesmerizes them, and then they're looking right at it for you. And I usually just hold this up with my muscle light at the same time, and I get a really good look at the light reflexes. So I think one of the keys is having some way to, hold the child's attention so they're looking right at you when you're shining the light. Because you're right, if they're looking off, then it's going to be hard to tell. Anything else? Well, if not, hopefully that provided some helpful information. I know checking kids' eyes can be daunting, and that's why we're here. We're always happy to see kids and take a look if you're worried about something or you're not sure about something. So yeah, I guess I'll just stay on for a couple minutes just in case somebody has a question. Otherwise, I think we're done.